Assalamualaikum and good day everyone. So this lecture is about hypertensive disorders of pregnancy. So it is one of the heart diseases during pregnancy, but it is only one of the heart diseases. There are many more heart diseases like arrhythmia or heart failure during pregnancy, but this lecture only covers the hypertensive disorders during pregnancy. The learning objectives of this lecture is to discuss the types and risk factors of hypertensive disorders of pregnancy. So what are the pathogenesis of pre-eclampsia, which is one of the type of hypertensive disorders. Discuss the treatment options of these problems and monitoring parameters during treatment and postpartum. Hypertension in pregnancy in general is one of the main causes of maternal, fetal, neonatal mortality and morbidity. Okay, it can occur in 5 to 8% of pregnancies, in which 15 to 24% of maternal death in developed countries are attributed to hypertensive disorders. So for the latest statistics or epidemiology of this disease in Malaysia, we can go to the National Obstetrics Report. So they will have all the information about the statistics of all the common diseases during pregnancy. So I did not include it here. For this topic, we will use the guideline of CPG heart disease in pregnancy published in 2016. Hypertension in pregnancy, the definition is the BP of more than 140 for systolic and more than 90 millimeter mercury for diastolic blood pressure. And it should be taken after a period of rest on 2 occasions until we can diagnose that the patient is having hypertension. And also, even if they do not have, they do not fulfill this, the first requirement to be diagnosed as having the hypertensive disorders in pregnancy, a rise of systolic blood pressure of 30 millimeter mercury and a rise in the DBP of 15 as compared to pre-pregnancy level should raise a concern for a careful follow-up. Okay, so we need to carefully monitor them if they have a certain increase in SBP or DBP during pregnancy. So classification of HDP, it can be divided into pregnancy-induced hypertension, chronic hypertension, or chronic hypertension with superimposed pre-eclampsia. So we will look one by one. For pregnancy-induced hypertension, it is defined as hypertension occurred after 20th week of pregnancy. Okay, 20th week of gestation or pregnancy in a previously normotensive woman in the absence of multiple pregnancy or molar pregnancy. Okay, so if the woman does not have hypertension before pregnancy or early on during pregnancy, she did not have any hypertension, but suddenly she had an increase in SBP or increase in DBP or the reading in 2 occasions of more than 140/90, starting from 20th week of pregnancy and above, so she can be defined to have pregnancy-induced hypertension. So we have these different terms under this pregnancy-induced hypertension. The first is gestational hypertension. It is pregnancy-induced hypertension without proteinuria, so it's a gestational hypertension. Pre-eclampsia, PE, is pregnancy-induced hypertension with proteinuria. Eclampsia is when the pregnancy-induced hypertension occurs with convulsion, in which the woman has seizure, and also plus proteinuria actually. Okay, so it plus proteinuria. And also another one is HELP syndrome. Okay, we will look further on the HELP syndrome. It is a more of a severe complication of pregnancy-induced hypertension. Okay. For the second class is a chronic hypertension. So it's the same like pre-gestational diabetes. It's when the woman having hypertension before she get pregnant, or when the hypertension is diagnosed before the week of 20 of gestation, and it continues even after 20th week of gestation. So it is called chronic hypertension. And the third one is chronic hypertension with superimposed preeclampsia. It's in which the woman already have hypertension before pregnancy or before 20th week of pregnancy, and it continues during after 20th weeks of pregnancy with a high BP, a worsening of high BP, and proteinuria or other health complications. Proteinuria defined here as either one of these. The first is more than 300 milligram of protein in a 24-hour period of urine collection. If you do the 24-hour urine collection, it's 1 gram per liter for or more in 2 randomly collected urine samples 6 hours apart, or a dipstick urine test of more than 30 milligram per millimole, or we can call it as 1 plus. So usually in the clinic kesihatan or any clinic, they use the dipstick urine protein test. This is the classification according to the International Society for the Study of Hypertension in Pregnancy. They classify it into 4, which is chronic hypertension, gestational hypertension, preeclampsia, or white coat hypertension. For the definition of preeclampsia and eclampsia, it's actually a combination of the of 3 points here. Okay, so the BP, the first is the BP more than 140 over 90 millimeter mercury. The second point is after 20 weeks of gestation. And the third point is the sign of damage to another organ system. For example, proteinuria. Okay, this is the definition of preeclampsia. If the patient have BP of more than 140 over 90, happens after 20 weeks of gestation, and have a proteinuria. So this is the definition of preeclampsia. Where else in eclampsia, they have these 3, and on top of that, the patient has convulsion. So this is when we call the patient as having eclampsia. Or if the patient does not have convulsion, but the patient might have any other indication of maternal organ dysfunction, the patient can be defined to have severe preeclampsia. So we will look further next. So now renal insufficiency can also occur as a sign of organ dysfunction, liver involvement like race and transaminase, or epigastric pain. Neurological problem, if they do not have convulsion, they can also complain of severe headache or visual disturbances. And also hematological disturbances, they can also have thrombocytopenia, low in platelet, coagulation disorders, or hemolysis. And we can actually look at measure the fetal growth as well. So the fetal can also have fetal growth restriction as the consequences to preeclampsia or hypertension in pregnancy. So this is what I mentioned before, severe preeclampsia. This is actually the definition from Royal College of Obstetrician and Gynecology. So there is a systolic BP of 170 or diastolic BP of 110 on 2 occasions, plus proteinuria of more than 1 gram per day, and the diastolic of more than 100 on 2 occasions with significant proteinuria 1 plus, and with 2 of the sign of the symptom of the following. So the severe preeclampsia can be defined of this, or the first or the second, the second presentation. And for the 2 or more sign symptom is from this following list. Okay, severe headache, severe visual disturbances, gastric pain, abnormal liver enzymes, IUGR, liver tenderness, okay, and also platelet low. So this HELP syndrome, like I mentioned before earlier, is actually a syndrome in which the patient have all of these 4 presentation. She could have the hemolysis, elevated liver enzyme, low platelets, and increase in LDH. If the patient have all of these condition, then she is defined to have HELP syndrome. So it comes together with severe eclampsia. So the complications of severe eclampsia, it can be quite quite uh, quite dangerous for the mother, especially because for the mother she could have cerebral hemorrhage or cerebral edema, encephalopathy, coagulopathies, or pulmonary edema, and all of this condition is actually life-threatening. Or she could also have liver failure. For the fetus, the uteroplacental perfusion can be compromised because in the development of hypertension itself, it can be due to a restriction in the blood flow from the uterus into the placenta. So due to this condition, the baby might not get the adequate supply of oxygen and nutrient. So their development can be stunted. And this is the definition of preeclampsia, superimposed on chronic hypertension. Can be diagnosed in the presence of any of the following: de novo proteinuria after 20 weeks of gestation, sudden increase in severity, appearance of features of preeclampsia, eclampsia, and a sudden increase in proteinuria in women who have pre-existing proteinuria early in gestation. So this is also another detailed definition of chronic hypertension superimposed with preeclampsia. So what are the risk factors of preeclampsia? So who are the women in which we need to monitor very closely, in which they have a higher chance to get preeclampsia or eclampsia? So it is divided into high risk factor and moderate risk factor. For high risk factors, it's the history of hypertensive disease in previous pregnancy. If they have hypertension in the previous pregnancy, they might likely to get that one also in the current pregnancy. Chronic kidney disease, autoimmune disease such as SLE, type 1 or type 2 diabetes, or chronic hypertension. So at least one of these factors, the woman can have an increased risk to develop preeclampsia and should be offered aspirin of 75 milligram OD from 12 weeks of gestation. For the moderate risk factors, it can include primigravida or nulliparity. So primigravida is the first gravida. So gravida is pregnancy, parity is delivery. So primigravida is the first pregnancy. So if it's a first pregnancy, the woman might also have a risk factor. It is actually a risk factor as well. Nulliparity, it goes along with primigravida. So nulliparity is they haven't delivered before. Age more than 40 years old and above. Pregnancy interval more than 10 years in between pregnancy, which is the previous pregnancy was 10 years ago or more. BMI of more than 35 kg per meter square, obesity at the first visit. Family history of preeclampsia, mother or sister, and multiple pregnancy, which can be twin pregnancy or triplet pregnancy. And also more than one or more of these factors might indicate an increased risk to develop preeclampsia, and can be advised to have a prophylaxis of aspirin 75 milligram OD from 12 weeks of gestation until delivery. Okay. So there are significant cardiovascular and hemodynamic changes in early pregnancy, in which it is meant to provide the embryo or the fetus with a healthy amount of oxygen and nutrient, and it will be important for the growth of the fetus. So the physiological changes during pregnancy might include an increase in maternal plasma volume. So the maternal plasma volume is increased, the blood volume is increased in during pregnancy, and also it can cause an increase in cardiac output, in which the heart rate is also increased to pump the blood to the placenta, and the systemic vascular resistance is reduced. And for some women, due to these physiological changes, they might develop pre-eclampsia or eclampsia along the way, and it can begin early in pregnancy, and because it can cause only subtle differences in the BP, for example, and it's not clinically evident. We cannot see any symptom, so we tend to miss that the patient is actually having high in BP earlier in pregnancy. The pathogenesis of preeclampsia can be explained by a few mechanisms. The first is the placental ischemia, in which the physiological changes within the placental vascular bed um, does not occur. So usually there will be changes in which in normal pregnancy there will be an opening of the cell placental vascular bed, in which they will increase the amount of blood supply to the placenta, or the blood vessels that supply for the placenta. So this will supply the fetus with enough blood supply. But if these physiological changes did not occur very well, so it might cause a reduced perfusion. So it can lead to placental ischemia, and this in turn leads to increase in the pressure of the blood. The second mechanism is through endothelial damage, in which there is an increased thromboxane A production, and it can cause increased vascular sensitivity, so angiotensin 2 and norepinephrine, and later on it will lead to endothelial cell dysfunction, vasospasm, and then lead to increase in BP. So you can have a further reading on the pathogenesis of preeclampsia. Okay. The key point in managing hypertensive disease in pregnancy is to lower the BP to prevent maternal complication, because as we have discussed before, the maternal complication can be life-threatening. So we want to avoid any cerebral hemorrhage, pulmonary edema, or liver failure, or cardiac failure. So our target is SBP of 140 to 150, and diastolic of 80 to 110. So we do not want to target lower than 140 actually. So these are the oral antihypertensive drugs that can be used for pregnancy-induced hypertension or preeclampsia. So the usual selection is either metidopa or labetalol, but nifedipine can also be used. Please refer to the Malaysian CPG for further explanation of this medication. For the methyl-dopa, this is pregnancy risk factor B. So it is if you know the US FDA, they developed the pregnancy rating scale of A, B, C, D, and X for all the medications according to its risk on the fetus. but this rating is actually outdated because they have replaced it with another type of labeling or labeling regulation. But it's just for us to refer to if we want to know what are the level of safety of any medication. So by the way, methyl dopa is risk factor of B, which means it's quite safe. It's among the first line agent for hypertension during pregnancy, centrally acting alpha agonist that decrease sympathetic outflow, so common side effects, dizziness, sedation. Okay, so the important thing is that methyl dopa crosses the placenta but has no association with the risk of congenital anomaly. So although it crosses the placenta, but the evidence shows that it does not cause any abnormalities to the fetus. Only that the risk on the infant, which is the newborn, they might have transient tremor, irritability, okay, and then decrease systolic blood pressure only for the first 48 hours of life. It is only a temporary effect of the newborn. For labetalol, it's pregnancy risk C. It's among the first line agents for hypertension during pregnancy, and it has a combination of alpha and beta antagonist properties, and it has a better safety profile than methyl dopa because it can cause less maternal hypotension, fewer cesarean deliveries, and no increase in perinatal mortality. So it does not decrease your uteroplacental blood flow even with a decrease in maternal BP. So it does not compromise the blood flow from uterus to the placenta. So the blood flow to the fetus is maintained. But labetalol should be avoided in women with asthma and decompensated heart failure, and it crosses the placenta. And the risk on infant or the newborn is neonatal bradycardia, which is low heart rate, hypotension, or and also hypoglycemia. So it's also the same, it will recover within 48 hours of life. For nifedipine, it's usually reserved for the acute treatment of severe hypertension during pregnancy. So we rarely see nifedipine as a long-term therapy. So it reduces BP without reducing uteroplacental blood flow or decreasing fetal heart rate. But it should be used in caution when given together with magnesium sulfate. So magnesium sulfate is being used when the patient also having seizure or convulsion. It cannot be given together with nifedipine because it might have a synergistic effect of a sharp drop in mother's blood pressure, and it will disturb the uteroplacental blood pressure. It can cause fetal hypoxia, which is the fetus do not have enough supply of oxygen. So these are the contraindicated antihypertensive during pregnancy. Atenolol, although it is the same group of beta blocker with labetalol, but this one is contraindicated. ACE inhibitor, angiotensin receptor blocker, thiazide diuretics. Atenolol can lead to fetal growth restriction. ARB, ACE inhibitor, and thiazide diuretics are associated with fetal anomaly and therefore not recommended in pregnancy. Whereas other type of antihypertensive, we don't have enough data on the safety on the fetus, especially. For example, diazepam, verapamil, amlodipine. So now we come to the hypertensive crisis and management. This is when we want to treat the severe preeclampsia or severe eclampsia, in which there is a high BP of 160, more than 160 over 110, sorry. The goal of therapy is not to normalize the BP, but rather we want to achieve the systolic blood pressure. So this is the goal of therapy of 140 to 150 for systolic, and 90 to 100 for diastolic. Okay, we do not want to normalize the BP until 120. Okay. First line agents are IV labetalol, IV hydralazine, or oral nifedipine. So oral nifedipine can be taken 10 milligram orally without biting, maximum of 30 milligram. And we cannot give sublingually. We just let the patient swallow, because if we give sublingually, it will cause a rapid reduce of BP. So please have a look at the Malaysian CPG. Okay, so look at the details of the table of how the drugs should be administered. Okay, so because this is an IV medication, IV drug, so it has a certain regimen. Okay, so for the anticonvulsion in preeclampsia, we use IV magnesium sulfate. It is currently the drug of choice, and it provides fetal neuroprotection following preterm birth with a significant reduction in the incidence of cerebral palsy. So meaning that it is not only protecting the mother, it does not only cut the seizure, but it is also good for the baby. It can have a fetal neuroprotection effect. The alternative is IV diazepam. So this is the regimen for magnesium sulfate. And also you need to monitor very closely as well for the signs of toxicity. Okay, and also respiratory depression and the risk of renal impairment in the patient. And the delivery plan is also important. We need to know when the patient should deliver. Do they have any deadline in which they cannot continue longer with they cannot wait any longer for the delivery to happen. For the chronic hypertension patient or gestational hypertension or white coat hypertension, meaning that they do not have that severe symptom, they do not have the convulsion or any organ dysfunction, it is no later than 40 weeks, which means that they can wait until 40 weeks to deliver. But if the patient also have proteinuria, which in the case of pre-eclampsia, not more than 37 weeks. Okay, if it's more than 37 weeks, there is a risk of complication, so they should not wait until 40 weeks. Postpartum monitoring, not only during the treatment we need to monitor, we also need to follow up them after they deliver, because there is also an increased risk for them to develop hypertension. So check BP regularly during the follow-up postpartum. Metadopate should be stopped within 2 days after delivery to avoid the risk of depression. The dose should be reduced if BP of less than 140/90. We can taper down the dose and then check regularly for the BP before we stop the medication. And once the BP is less than 130, we can reduce or we can consider to stop. So consider starting antihypertensive agent if BP is more than 149/99 in patients not having gestational hypertension. So this is when the patient do not have hypertension, but then postpartum, if they start to have an increase in BP, they should be diagnosed with hypertension. They should be undergo any further follow-up. So women with GH, gestational hypertension and preeclampsia should be monitored for BP regularly and discussed for future pregnancy plan. So if they have especially if they have a hypertension, we need to plan for the future pregnancy, because they need to have a stable or a controlled BP before they can plan for another pregnancy. And when they are breastfeeding, so they can continue to use labetalol and now ACE inhibitor. Only these two options, enalapril and captopril, can be used during breastfeeding, and atenolol and metoprolol can be used, and also nifedipine. The safety is not yet established in this selection, ACE inhibitor other than enalapril, captopril, ARBs, or amlodipine, and the patient needs to avoid diuretics during breastfeeding. These are the references that I use for the lecture, and thank you very much for your attention.